I guess there can be quite a number of pains associated with stroke itself, not least the ones that are associated with changes in brain functioning following stroke, the so-called central stroke pain, thalamic pains, but also some of the pains associated with the secondary effects of having a stroke, the musculoskeletal problems associated with hemiparesis, for instance, and also neuropathic pain associated with the stroke as well, on one side or the other of the body. Most patients will tend to describe their pain in a multitude of ways. Some patients may describe their pain as variously burning, aching, internal, various specific descriptors like that. But other patients will describe their pain really as how it relates to them emotionally. So many patients will tend to describe their pain as intolerable, as insufferable, use language like that, which really conveys the sense not just of the nature, the physical nature of the pain, but the impact it's having upon them emotionally as well. There's a great wish, and a very understandable wish, for health professionals to try something and do something that will have an immediate or a quick impact upon the pain. But my view would be that actually the things that we do sometimes that we don't see as direct interventions can have a huge impact. And I'm thinking more in terms of the sorts of interventions such as simply listening and validating patients' experience. One of the problems with chronic pain for a great number of patients is that they are concerned that they won't be understood, or that their pain won't be understood, or indeed that they won't be believed. So I think a hugely therapeutic first step for many health professionals working with stroke patients can be in simply taking the time to listen, understand, and spend a bit of time validating what the stroke patient is actually saying to them about the pain. And the sort of phrase that we tend to use in the pain clinics is that whatever the patient says their pain is, that's what their pain is. It's as simple as that. So I think those things that perhaps are seen to be a little touchy-feely are actually incredibly important for all health professionals to be doing before we rush in with specific interventions. I think that we're seeing quite a number of primary care developments in a range of different sort of areas here for pain patients to access. And you know, the third sector particularly taking quite an initiative now in terms of helping patients access pain management in one form or another out with the pain clinic, and certainly out with psychology. I think we always need to ensure, though, that the types of interventions that patients are given out with pain clinic match that particular patient's need. And where there are more complex issues, either in terms of biological presentations, but also psychosocial presentations, that the pain clinic is always considered in those sorts of cases. The types of patients that are probably most suitable for psychology are those ones who tend to be displaying high levels of distress, high levels of frustration, confusion about the nature of their ongoing pain, or where other factors such as fear of movement or fear of pain are becoming as much of a disabling factor as the pain itself. Beyond that, I think Also, being aware of the patient's willingness to engage with psychology can be an important factor to think about before assessment as well. Sometimes psychology can be seen in particular ways by particular patients, and it's not unreasonable for some patients to be a little bit concerned about the role of psychology, and perhaps are a little bit fearful that psychology is suggesting that the pain is in their mind in some ways. So I think spending a bit of time addressing these sorts of issues with patients before making referrals can be incredibly important, as well as giving patients a real good sense beforehand of what to expect from a psychology referral. Those are the sorts of factors that I think are important when considering such a referral. I think it's important for potential referrers to think a little bit, or be aware certainly, that there can be a number of psychologically based interventions available within a pain clinic that do not require the intervention of psychology, and therefore those long waiting lists. So there can be quite a number of interventions, such as patient education classes that post-stroke pain patients can access much quicker.